Hello. Good. Good morning, everyone. Welcome to the AFCRN online meeting. Go. Good morning. Good morning. Let me just hold. Good morning, everyone. Welcome to the AFCRN online meeting. Bonjour à toi. Bon dia. Today, we shall have 9 speakers to introduce their studies, and I will give a bit of update on what the latest activities of the Network and the Coordination Center is doing in 2020. So now I would like to pass the stage to Anne Curry, who is the head of the Nairobi Cancer Registry within the Kenya Medical Research Institute in Kenya. Dr. Curry, the floor is yours. And you are muted.
All right. Thank you, Bing. Good morning and good afternoon, everyone. It's so good to see many of you. We haven't met in a while. I think it's more than a year since our last meeting because the meeting we were meant to have this year could not take place because of the current situation. So it's really nice to see all of you connected virtually for this very important meeting. As Bing has said, my name is Anne Korir. I am the head of the Nairobi Cancer Registry at the Kenya Medical Research Institute in Nairobi, Kenya. And most importantly, we are members of the Africa Cancer Registry Network. And this network has really grown over the years. We came together in 2012, the year 2012. That's when we formed this network, and I'm so glad to have been part of the initial development of this network, and watching it grow over the years has been really a privilege, and we are so happy and pleased with the work that each of you are doing in your various countries. I know that cancer registries face enormous challenges. We have issues of limited resources, limited support from our governments, and many difficulties that we face even as we do our work. But I wish to encourage each of you that we will shoulder on, and for sure, I think and I believe things are getting better. And over time, many governments have now seen the importance of cancer registry work. Many people are using the data that we generate, and we know how important this data is in informing cancer control programs, planning, in patient care, in research, just to understand, the etiology of cancer. So really our work is so important, and I really appreciate the efforts that are being put in by each of the members represented here today, and even those who are not able to join us today. So mine is really just to give an opening remark and to welcome each of you to this very important meeting. There is a lot of important work that has been done by the various registries across Africa region. I know that we are still not quite there where we want to be, but really we have made tremendous efforts, and the number of registries have increased over the years, and we are seeing better quality of our data over the years. And I encourage each of us, to keep putting in the efforts that we need to put in so that we continue to generate high quality data that can be used for research. Today's forum, we're going to listen to various speakers who are going to share the research work that they've been doing over the years. And this is data that is generated by many of us in the cancer registry field. So this is a very, very important forum. And so I'm happy that you are all able to connect in. I really want to also emphasize and to really thank the leadership of our network. I want to specifically thank Professor Max Parkin, Ms. Being Liu. Thank you for all the work that you do in the network, keeping us updated and just coordinating all the work of the Cancer Registry Network. We are really grateful for that. And I also want to thank all the leaders of the cancer registries across the Sub-Saharan Africa region for your leadership and for the work that you do in your registries, given the many, many difficulties that we face. Even currently with the pandemic, I know that a lot of us are facing many, many challenges. Most of our registries, we rely on volunteers. And some of our institutions have really had to stop the work of the volunteers because, as you know, they are not under any medical insurance and all that. So it's affecting our work. But we are hoping that things are going to get better. And hopefully next year we should resume our work and be able to continue doing what we do. So mine is really to thank each of you and to welcome each of you to this meeting. Yesterday, there was the launch that was done by World Health Organization, WHO. They launched the global strategy for accelerating elimination of cervical cancer. And there is no region that cervical cancer has hit more than Sub-Saharan Africa region. And I was so keen listening to that report, and I wanted to see what has been put in place for cancer registries, because for us to even be able to monitor and say, yes, we've been able to eliminate or to reduce mortality due to cervical cancer, we need cancer registries. So my hope is that with time, even as WHO launches this strategy, there will be resources available to the cancer registry so that we can do proper monitoring of the interventions that are put in place. So I don't want to take much time. I want to just thank each of you for being here and to encourage you to continue doing what we do in the cancer registry field. Thank you, everyone. Thank you, our speakers, and everybody who is connected here today. Thank you and goodbye. Back to you, Bay.
Thank you, Corey, Dr. Corey. I wish you a safe journey today. I know you're traveling a long way, 5 hours by car. And thank you for making the time to do the opening for us.
Thank you.
Bye for now, and we will talk soon.
Yeah.
Our next speaker is Dr. Yvonne Joko. She was a doctor in Cameroon, and now she's pursuing her PhD at the University of Oxford under the supervision of Dr. Parkin. And she will be talking about cancer surveillance in Sub-Saharan Africa. The floor is yours, Dr. Joko. You are muted.
Good morning, everybody. Can you see the slides presented?
Yes, very well.
Okay. So good morning once more. So this morning, on behalf of the African Cancer Registry Network, I will be presenting on cancer surveillance in Sub-Saharan Africa. This work I'm presenting is work which has been done by all members of the African Cancer Registry Network, and I will just be presenting how this network has contributed to cancer surveillance in Sub-Saharan Africa. So why do we need cancer surveillance in Africa? Africa has a population of 1.1 billion people, and this population is growing at very rapid rates. Coupled with this increased population, we have increasing life expectancy and aging populations. In addition to this, we have coexistence of both infectious and non-communicable diseases. Furthermore, our diets and our lifestyles are changing and they're becoming more westernized. We have foods which are more processed. We have women who have fewer children. We have breastfeeding, which occurs for shorter durations of time. So all of this may contribute to increase some of the cancer incidence observed. Now in sub-Saharan Africa, the graphic we see on the left is an image from Uganda in which we see the records section. So how do we go from what we see on the left to the graphics which we have in GlobalCan, in which shows the prevalence of the most common cancers in Africa in 2018. Much of this has been done by the work of the African Cancer Registry Network. This network brings together 35 population-based cancer registries. It was formally inaugurated in March 2012. Bing is going to give us a lot more information about the registry in the following presentations. The work of the registry is supported financially by the International Network for Cancer Research Challenge Fund and the Global Initiative for Cancer Registry Development. But I cannot go on without mentioning some of the pioneers of cancer surveillance in sub-Saharan Africa. I will start on the image on the left. It's an image of Dr. Dennis Burkitt, who in the 1950s and 1960s did a safari, a map showing the different places where you have Burkitt's lymphoma in Africa. And this was one of the first cancers which was linked to an infectious causes, which is the Epstein-Barr virus. And he was one of the first people to map the geographical distribution of cancer and to show that some of these distributions, they vary with the climate or some exposure to some infectious diseases. And on the right, we have Dr. Max Parkin. This is an image from the 1990s. And he has been working in cancer surveillance for more than 40 years. And a lot of the data we have and the results we are presenting today is thanks for all the work he has put in along the years together with the registry staff. In this picture, we have Dr. Wabinga and we have Sarah, both of the Kampala Cancer Registry. Now, what do we have presented on the incidence rates for cancer in sub-Saharan Africa? This graphic shows the number of countries represented in cancer incidence in 5 continents. The cancer incidence in 5 continents brings together all population-based registry results of sufficient quality. And we discovered that not more than 5 registries from sub-Saharan Africa are included in any of the previous volumes. And what we can equally highlight is that for consecutive volumes, we have only 2 registries, Uganda and Zimbabwe, which have featured in 5 consecutive volumes of cancer incidence in 5 continents. This means that although a lot of work has been done in increasing the quality of registrations, we can still do more to make sure we have more of our registries featured in cancer incidence in 5 continents. I equally want to highlight that cancer registration in Africa is still very much an active process. In some parts of the West, like in Europe, in the US, most of this registration is passive. But in sub-Saharan Africa, this is active. The registrars and the staff actively document all of these cases. So it is generally a lot of work, and the data they collect is very precious because without this data, we cannot monitor and we cannot evaluate any of the policies which we are putting in place. I want to mention this book. It's called Cancer in Sub-Saharan Africa, Volume 3. This is a collaborative effort of 31 registries. So although some of these registries may not feature in cancer incidence in 5 continents, they still generate data which we can use to monitor the current burden of cancers in these registries, and equally use this as a basis to make projections of future incidence trends. So from the work of the African Cancer Registry Network, what have we been able to learn so far? First of all, in sub-Saharan Africa, we need to note that the most common cancer are cancers of the breast. Initially, these were cervical cancer, but we see that in terms of incidence, breast cancer now surpasses cervical cancer as the #1 cause of cancers in sub-Saharan Africa. But in terms of mortality from cancers, cervical cancer is still responsible for the greatest mortality rates for cancers in sub-Saharan Africa. Other common cancers we have are cancers of the prostate, colorectal, and liver. So what we observe is that the picture of cancers are changing from what was observed in the 1990s. In the 1990s, we had more of Kaposi sarcomas and cancers which are attributable to infections, but now we are seeing a rise in cancers which are caused by some lifestyle factors. Some other important outcome from the work of the African Cancer Registry is the work on infections and cancer. From this work, we have discovered that 29% of cancers in sub-Saharan Africa are attributable to infections. So 1 in 3 cancers in sub-Saharan Africa are attributable to infections. And 2/3 of this can be prevented by vaccination, with an emphasis on HPV and hepatitis B vaccines. So we celebrate the WHO's launch yesterday of the Global Elimination Plan for Cervical Cancer, and we hope that the registries will be an important tool to monitor this new trust. What about NCDs in sub-Saharan Africa? In addition to infections, we have changes in our lifestyle. This shows the percentage of women with BMI above 25, so women who are overweight. So this shows data from Zimbabwe and Uganda. So we see from the 1990s to 2020, we see a progressive increase in the BMI of women. Being overweight or being obese predisposes us to have some types of cancers, as well as cardiovascular diseases and diabetes. In addition to this, we see that the smoking rates in Africa, although lower than in Western countries, are on the increase. And smoking is most common among adolescents. Smoking, which starts early, predisposes us to cancers of the lung, as well as other cancers of the upper digestive tract. This is another important outcome. We're looking at trends in the incidence of cancer in Kampala for the last 25 years. So thanks to the work of the registries, it is now possible to monitor cancers over long-time trends in sub-Saharan Africa. And what we observe from these trends in Uganda, we see a decline in some infection-associated cancers like cancers of the liver in the recent years, a decline in Kaposi sarcoma, which is related to HIV incidence in these countries. We see a decline in non-Hodgkin's lymphoma. But on the other hand, cancers such as cancers of the esophagus, cancers of the breast, cancers of the prostate, and cancers of the colorectal are on the rise in this registry. And this picture is mirrored by several other registries in sub-Saharan Africa. In addition to the work in studying time trends across different registries in Africa, the registries of the African Cancer Registry Network equally produce reports, registry reports, which are specific to their registries. These are examples of different registry reports from different African countries, and these reports contribute to the national cancer control plans. So we cannot evaluate any of the cancer control plans without the evidence to back and to show the outcome of any of the interventions we are doing. So this is why these registry reports are a primordial and very important part of the cancer control plan. In addition to this, the registries have equally contributed to the study of incidence, stage, and survival for the most common cancers in sub-Saharan Africa. These are some examples of the publications. So we have examples from breast cancer, which brings together 14 registries, prostate cancer, trends in cervical cancer, and childhood cancer. So in addition to work done on individual registries, there's a lot of work which is being done in pulling together the results from all the registries so we can have a more holistic view of what are the trends, what are the cancer trends in Africa. So why is any of this necessary? It is important for us to be able to evaluate the current cancer burden in Africa. We need to be able to define what are the priorities for cancer control in our respective registry areas. It's important for monitoring the progress of interventions, and it is an essential component of any of our national cancer control plans. All of this work is a story of partnerships and collaboration. This work would not have been possible without the work and collective effort of a lot of partners, some of who are present here today. And we say thank you for your generosity and for all the support given to the African Cancer Registry Network. But in spite of this, there are lots of challenges which we still face. Some of these include, we need to ensure the continuity of the registry activities. Many of these registries suffer from lack of sufficient funding, lack of enough trained staff. So we need to invest in these registries to permit us monitor the cancer burden in sub-Saharan Africa. We equally need to build sustainable research environments in Africa so that we can use the data we generate to understand our cancer burden and be able to conduct research which is relevant to our continent. In some of these areas, there is political and economic instability, which makes the continuity of some of the registration activities precarious. And we need to continue to make our research count. So it's not enough just for us to record this number of cases, but we need to use this data to inform policies such that the policies made in Africa are evidence-based. So why must we keep going on in spite of these challenges? Because behind these numbers, behind these graphics we present, there are countless numbers of premature deaths, some of which are preventable. So if we record this, we can serve as advocates to advocate for changes and to advocate for evidence-based cancer control policies in Africa, which are not driven just by models, but which the underlying is actually data from sub-Saharan Africa. So thank you very much for listening, and thank you for all the work which has gone into producing these results. Thank you.
Thank you, Yvonne. Thank you for this excellent talk. If anyone has any question for Yvonne, we can do the question and answer at the end of this session. The next speaker will be myself, and my talk will be introducing the network. Let me share my screen. Once again, good morning, everyone. Bonjour to the ones who just joined. This is the presentation presenting the African Cancer Registry Network. For those who didn't know about this network before, the journey started 11 years ago, 2009. And throughout the past 8 years, we have worked with many international organizations and research bodies. And here are the only few significance presented on the slide. And as today, we have 35 members in 25 countries. As you can see on the map, which Yvonne has presented as well, and each dot has presented our current members. The names in oranges are the latest member who joined this year. Our network only includes population-based cancer registries, and their minimum coverage of the population is 50%, and they have to reach 70% within the 3 years of joining. And if they fail to do so, we will have to assess again. And each member of the registry will send their entire database to the network. And it includes 16 minimums of variables, which, as Yvonne has shown, the data has contributed to many of the studies. Our main goal is to increase the number of registries in the continent, as well as improve the quality of the data generated by our members. Together with the International Agency for Research on Cancer, we are executing the following 4 scope of works: consultancies, training, advocacies, and research. Here are some of the examples. When we do consultancies, we will send our experts to the field to do assessments and evaluations. They will provide technical support and advice. For training, we will sometimes send our trainers to the field, or we will bring in the students into the training centers. We have 4 types of training programs: the basic training courses, advanced training courses, workshops, and mentorships. The use of database is mainly our database is the only source of information for making national estimates for cancer incidence, mortality, and prevalence for the continent. And the current exercise will be Global Can 2020. Although we all do our best, the quality of data can vary from year to year, from registry to registries. For the ones who meet the international criteria, they were included in the famous books, Cancer Incidence in 5 Continents. As the network ourselves, we periodically prepare monographies to present to bring together all the data from all member registries. And here are the 3 most recent books we produced: 2 on adult cancers and 1 on childhood cancers. I would like to showcase our latest publication, which was published by the UICC. This book included data from 31 members. And the book consists of 2 major components. One part is results by registries. Within that session, you will see the brief description of each participating centers, followed by their own detailed results. The other part is discussion by site. We have chosen 13 most common cancer sites in the continent. Our data were presented in both tables as well as graphs. And best of them all, this book is free to download. And if you go to the UICC website and search the name of the book, and you will be able to find it. So activities this year. In terms of training, we managed to carry on an introductory course over Zoom. It included 40 hours lecture time, and over 60 students joined. And another big piece of exercise is we are collaborating with IARC and Vital Strategies. Together with Bloomberg, we are translating the traditional teaching materials into online training platforms. So the regular user PowerPoints and lecture notes will be translating into very active, interactive, and attractive PowerPoints and online sessions. This includes 15 modules. 14 of them are shown on the table below, and plus the childhood cancer registration module. So we say we never miss them. Please mute yourself, other speaker, non-speakers. We say that we never waste the opportunity created by disasters. So we use the free time we gained from this lockdown. We managed to put together all the PowerPoint publications. Sorry, I'm just trying to mute everyone. Okay. So so far we have published 9 publications in peer-reviewed journals. and a few more are in the oven, soon to come. Other activities. Together with IAC, we are finalizing the latest essential TNM staging chart, and we are actively looking for funding to help testing this chart. The other ongoing program is continuing our exercise within Tanzania and Zambia, which is funded by the Bloomberg Data for Health initiative. We nearly started one program in the Southern African countries. It's the childhood cancer registration. This is, Natasha will give a detailed presentation later. And another two exercises in Rwanda. One is linking the DHIS2 together with CanReg, and the other one is linking the verbal autopsy database together with the registry database. Another exercise we would like to start soon is the access to care and treatment survey. And the objective of this survey is, sorry, I just have to mute someone again. The objective of this survey is to investigate the type of treatment that's available and what is actually being used. And we will look into the reasons why, if they were available and was not used. And this exercise will be carried out by completing questionnaires. And we will aim to cover 6 adult cancers and childhood cancers as well. And there will be 2 separate questionnaires. And if you're interested, please contact Dr. Connie. Potential funding. We have been lately talking to someone from this City Cancer Challenge. This program was initiated by UICC 2-3 years ago, and now it's an independent program based in Switzerland. They are accepting letter of interest, and the deadline for letter of interest is 1st of December. You can please note the website on this slide, and here's some of the criteria. They are looking for cities with more than 1 million residents, and only NGOs and non-governmental organizations can apply. And you will have to have a very clear plan what to do. And the general support lasts 2 to 3 years. And last but not least, I would like to congratulate Dr. Parkin for getting yet another award in his lifetime, for thanking him for his continuing contribution to different parts of the world. So what's next? Where do we go from here? You will have seen this picture in Dr. Joko's presentation. This is a picture taken 2 years ago during our latest annual meeting. We planned 2 following conferences after this one, but we both had to be canceled due to the COVID pandemic. But we still have the support from the Volkswagen Foundation, and we are seeking a suitable host as soon as the international travel is feasible and safe to do so. That's all of my presentation, and if you have any questions, please feel free to contact me. Okay, so let me introduce the next speaker. Our next speaker is Dr. Omonisi. He's a pathologist and a lecturer at the Ekiti State University Teaching Hospital in Nigeria. Dr. Omonisi, are you ready?
Yes.
Please share your screen. You may start as soon as you are ready.
Can you see my slide?
Yes, we can.
Okay, thank you very much. Well, I bring greetings from Nigeria, West Africa. I'm very delighted to be part of this great meeting. So I want to thank Professor Mike Parkins for inviting me to share my thoughts on this topic. How do we fit into the global cancer control? And specifically, I'll be addressing the role of cancer registration in Sub-Saharan Africa. I'm Omonisi Abidemi Emmanuel. I'm the founder and the director of Ekiti Cancer Registry, that is domiciled at Ekiti State University Hospital, Ekiti State, Nigeria. And the cancer registry is hosted at the Cancer Center, that is built in honor of our late deputy governor that died of breast cancer in 2013. And then the highlight of my presentation will be the historical perspective of cancer registration in Sub-Saharan Africa. We'll also look at the role of African Cancer Registry Network in strengthening cancer registration in Sub-Saharan Africa. Then we'll look at the current status of cancer registration in Sub-Saharan Africa. Then what are the future direction? My heart bleeds anytime I attend international meeting and I hear people say there is no data in Africa. But we know we have data in Africa, particularly data on cancer. I must thank Africa Cancer Registry Network, and other partners, for making this happen. About 70% of newly diagnosed cancer cases are occurring in low and middle income countries, where the survival rate of cancer is 30 to 50%. Africa accounts for about 6% of the world cancer body. Cancer indeed is not rare in Africa. And most of us here know that cancer registry provide for the systematic collection, storage, analysis, interpretation, and reporting of data on subjects with cancer. You saw around Africa geographically located, our country south of, Sahara, and UN Development Program lists 46 of the African 54 countries as Sub-Saharan. These countries share many characteristics and challenges in common, but not limited to lack of adequate access to basic health care, poor health indices, and extreme high mortality rates. The region has the highest prevalence of HIV/AIDS in the world, and also AIDS cancer associated with AIDS malignancy. And most of the country in Southern Africa actually won, and infectious diseases are very predominant in this region of the world. And by way of historical perspective, we know that cancer registration started in Southern Africa via case series, and subsequently the first population-based cancer registry, which is the Kampala Cancer Registry, was established in Kampala, Uganda in 1954. And there was a slow rebirth of cancer registration that had been taking place since 1980. It's important to note that as of today, we have 24 functional population-based cancer registry in Southern Africa that have high quality data that could be used to estimate for the national cancer profile. I'm an active member of Nigeria National System of Cancer Registry, and I know we have a very well organized national system. I just want to say one or two things concerning our national system of cancer registry. The first cancer registry in Nigeria was established in 1962 by Professor J. Meditin at the University of Ibadan Hospital. Between 2001 and 2009, there is no serious cancer registration activity in Nigeria. The second attempt at establishing a central coordinating body for cancer registration in Nigeria was instituted in 2009. The national system, with the support of Nigerian government, actually made this happen. As of today, we have 20 hospital-based cancer registry and 14 population-based cancer registry in Nigeria. And this map shows the various distribution of the registry. And the national system, is being supervised by the Federal Minister of Health in Abuja. And we have excellent relationship, with the host institution and also international partners. And basically, we're involved in logistic and scientific support, training and capacity building, mentoring and monitoring of Nigeria Cancer Registry. The African Cancer Registry Network was established in 2012, and they currently serve as the IAC, regional hub, for cancer registration in Southern Africa. By 2012, its membership had grown from 16 member countries in 12 countries to 35 in 25 countries. It's very important. The network has provided training, technical support, research, coordination, networking, and advocacy for population-based cancer registry in the region. And most importantly, the network has created a very robust and very unique database for cancer in sub-Saharan Africa. And this map has been displayed earlier on, showing the distribution of various population-based cancer registry in the region. The network has, supported the population-based cancer registry, in publishing technical reports and also, article in high impact journal. As just a few years ago, the network, was to produce the voluntary of cancer in Southern Africa, and these are other publications. These are just a few of the, articles that we published in high impact journal. You can see incident of cancer in Nairobi, Kenya. Cancer incident in Guinea Conakry. Cancer incident in northern Uganda, just to mention, few. So what are the role of cancer registration in Southern Africa? Number one, that is very crucial, is that the data from population cancer registry are very important in establishing national cancer control program. In Nigeria, data from national system was very, very vital in the publication of Nigeria National Cancer Control Plan 2018 to 2020. And secondly, this data could be used for healthcare planning. Recently we published our experience at IFE, Asia Cancer Registry, and in that report, we're able to audit the oncology practice in the hospital, and we highlighted, some deficiency in the system, and I'm glad to report that, those deficiency, have been, being addressed, by the management of the concerned hospital. And thirdly, is very, very important for healthcare monitoring. I'm happy that the global eradication for rare cancer was launched yesterday by WHO, but you need the cancer registry to monitor the trend over the years, whether truly the intervention will work. Just like in the Gambia, in the early 80s, hepatocellular carcinoma, was the topmost cancer in that country, and then WHO intervened, through the Gambia intervention study, a trial vaccine hepatitis was introduced in the country, and the impact of that project was monitored, 20 years after, and it was found to be very, very effective. And as we speak, the incidence of hepatocellular carcinoma in the Gambia has seriously declined. And most African countries have actually adopted that strategy, and now hepatitis B vaccination is something that that Monisha in Africa carry out. And the incidence of hepatocellular carcinoma in the continent is on the decline. And then fourthly, this data could be used for ethnological research. We may be interested in public, investigating specific ethological agents and the link to, certain cancer. Just like the article, published by Parkins, Cancer in Africa 2019. Also in Nigeria, Debamo, Micah and others. Also, published, these two articles actually link infectious agents to, podium cancer in Nigeria and also alcohol. And then, quickly we know that one of the major, challenges that we have in Africa is lack of, political support, and that's why most cancer registry we continue to rely on foreign partners, because the politicians are not interested. There is no vote, no funding, for cancer registration, and that's why it's important, for us to carry out advocacy. In our registry, we discovered that, and we launched several, cancer advocacy visits to the politician, to the health worker, to media houses, and several, other stakeholders. And then intervention really worked, and then that culminated in this program, cancer screening program in our state. There was a partnership between the Ekiti State Sustainable Development Goal Office, the Office of the Wife of the Governor, the Ministry of Women Affairs and Social Development, the Ministry of Health, and our cancer registry. We organized cervical and breast cancer awareness program and screening program. And then that program, we're able to screen 3,000 women in all the 3 senatorial districts, in our state. And by way of future direction, we have a robust data. What we do, apart from publication. This data could be linked to biorepository, and that is very important. We can also conduct survival study, In one of our registry in Nigeria, the Calabar Cancer Registry, has a grant to actually conduct survival study. This data is also available, to interested, researcher, which they may also publish from in a collaborative work. Also important to engage the community and the society, so that we can have community and society buy-in in all our activity. In conclusion, the registry provides a unique resources for measuring cancer burden in a population. We also know that cancer registry play a pivotal role as the backbone of any successful cancer control program. And then lastly, we know that countries, Sub-Saharan Africa, need a working cancer control program, to battle the ever-increasing burden of cancer in the continent. I must, thank, my staff at Cancer Registry, Federal Ministry of Health, Nigeria Conference Network, and also Cancer Institute. And as a final takeaway, we must understand that population-based cancer registry is no longer an elephant in the room in Sub-Saharan Africa. However, the resources for their development must be prioritized urgently. The above is very, very important, as the current over-dependency on donor agency may not be sustainable in view of the emergency, global financial crisis. And for further information, I want to recommend that you please download and read, this article that was published last week, by, my humble self, Professor Markins, and also the new Type 2 Population-Based Cancer Registry in Southern Africa, is role in research and cancer control. On this note, please permit me to sincerely thank Professor Miles Parkins, for all what he has done for Africa and what he continues to do in Africa. I want to sincerely thank you for the excellent collaboration, between my team and Professor Miles Parkins. Thank you for mentoring, young investigators like me in Africa, and thank you for everything you've done. I sincerely thank you for listening. I'm happy to take your question at the end of the lecture series. Thank you very much.
Thank you, Dr. Omonisi. Thank you for the excellent talk. And thank you for highlighting yet again the importance of cancer registration for all the good for cancer patients in the continent. And it's very interesting to see how many activities going on in Nigeria. And also in recent years, we can see many more dedicated researchers like yourself and Professor Femi making a lot of efforts and trying to engage governments and trying to improve the registry performance in a very busy country within a very busy schedule as well. Our next speaker is Gisbert Munsiwa from Tanzania. Gisbert? So Gisbert is an in-country coordinator of the vital strategies. He coordinates the activities within Tanzania, which is supported by the Bloomberg Data for Health initiative. And we are working closely with him on the cancer registration, National Cancer Registration Program in Tanzania at the moment. He has been wonderful help to us. Gisbert, you may start whenever you're ready.
Okay. Thank you, Bing, for your introduction. So I will be sharing the experience of cancer registration in Tanzania on behalf of Dr. Sarah Mongezi, who is a coordinator of cancer issues at Ministry of Health, Community Development, Gender, Elderly, and Children. So the Ministry of Health, Community Development, Gender, Elderly, and Children has established the 5 population-based cancer registries across the country. This helps the Ministry of Health in a systematic and continuous process of registering every case of cancer diagnosed over a given period in a well-defined geographical region. So we have the 5 functional registries which have been distributed all over across the country, as it is indicated in the map, whereby at the Lake Zone, we have the Mwanza population-based registry at Bugando Medical Center. At northern part of Tanzania, we have the Kilimanjaro population-based registry at Kilimanjaro Christian Medical Center. At central part of Tanzania, we have the Dodoma Cancer Registry at Benjamin Mkapa Hospital. And on the southern highlands, we have the Mbeya Population-Based Cancer Registry at Mbeya Zonal Referral Hospital. And the last one is the one which is present on the eastern part of Tanzania, which is Dar es Salaam Population-Based Registry at Ocean Road Cancer Institute. So we have a number of goals that we have set in order to achieve the interventions under cancer registration, whereby number one is to establish and strengthen the national population-based cancer register leadership and infrastructure, provide the site-specific support for improving the registry functioning, analysis, and collection of information across Tanzania through effective cancer registration and surveillance. We aim at monitoring and evaluating cancer registry services at all healthcare system levels, and lastly, conduct cancer research and produce the publications from cancer registry data. Having got the collaboration from the government, the good cooperation from the government at large and some of the partners who are supporting the cancer registration activities in the country, we have achieved a number of issues that we planned. Number one, we have managed to train 28 staff on cancer registration from all the 5 registries, and these are including the directors, registrars, and other staff from registries, as well as the central Minister of Health. The new population-based registries, 2 of them have been established, and we are continuing strengthening 3 population-based registries under the Minister of Health. The other 2 population-based registries, which are Mwanza and Kilimanjaro, have been given a full membership of African Cancer Registry Network. This has been achieved after meeting the criteria that have been set. And one, which is Dodoma, a registry, has a provision membership. We have also managed to come up with a cancer registry strategic plan 2019-2022, which is now being used when we run the all 5 registries. We managed to conduct sensitization on cancer registration activities to all stakeholders who participated in the meeting of launching a cancer program in the year 2019. As part of disseminating data which are being collected through cancer registration, we have managed to include some of the indicators in the 2019 annual health sector performance profile, which is going to be presented next week in the joint annual health sector review meeting. In order to enhance the institutionalization of the activities, almost all registrars that are being used in the registries are government employees, with an exception of Mwanza and the Bugando registries, whereby each of the registry has one registrar who is not the government employee. These registrars are being paid by different partners in order to make sure that the activities are going well in the specific registries. We are also continuing to work on costing of cancer registration activities, the activity which is almost at the end, and the report will be handed over soon to the government. So, as part of improving the technical issues within the registries, we have a routine base activity whereby the experienced registrar, who is Mr. Franco, working at Mwanza Registry, always passes through the registries to provide a technical support. In the photo that you see has been displayed is Mr. Franco, who was providing a technical support to registrars and other staff of the Dar es Salaam Registry in Dar es Salaam at Ocean Road. So we are expecting in the coming few days to establish a central coordination office, the activity that has already started to set up some of the area preparatory activities, which will be able to oversee all cancer registration activities at the ministry level, as well as the registries. And this coordination office will be situated at the non-communicable diseases section under the Directorate of Curative Services. We are also aiming at creating a central database and embed it into DHIS2. We are aiming at integrating this database with other systems like the CRVS system. We are targeting also continuing disseminating cancer registration activities through the national health reports, like the National Vital Statistics Report that has been started being produced this year in Tanzania, the National Health Sector Performance Profile. This will be a continued activity since this year we managed to include some of the indicators from Cancer Registration Program. We will continue including the information from cancer registration into the annual statistical tables and figures, all these reports which are produced by the Ministry of Health in collaboration with other agencies like the CRR, the National Bureau of Statistics. We will also keep on running the 5 population-based registries together with the strengthening the functionality of the central coordination office. Apart from all these achievements, we are still facing some of the challenges. And number one is that having the CANREC database in place, though it is not integrated with other systems like DHIS2, systems like the civil registration and vital statistics, whereby we are targeting or thinking that in the near future we will have to integrate it with the system, ministries system, which is DHIS2, as well as the civil registration and vital statistics system. We are also having unsustainable financial resources, whereby currently we are being financed by Bloomberg Data for Health Initiative and the African Cancer Registry network and other partners as well. So the registries are working on themselves with some of the few resources that they have to make sure that their activities are keeping on and they are going on. And the Ministry of Health is working very hard to encourage the registries to use their own budgets through the revenues that are being collected from the hospitals so as to enhance the sustainability of the activities. We are also having some of the temporal staffs from Mwanza Registry and Kilimanjaro Registry who are helping the registries to make sure that they are running the activities as planned. So we are also keeping on encouraging them to make sure that they deploy the government officials as registrars for enhancing the institutionalization. So this is all. Thank you very much. In Kiswahili we say asanteni sana.
Asante sana. Thank you, Gisbert. Thank you for the talk. And everyone knows it's how difficult to bring everyone together within a large country and get them to work on the same timeline is even more difficult. So Gisbert has been a great help, and he plays a very important role in this national program. And our next speaker will be Yvonne Joko again. Yvonne, you ready? Dr. Joko. Good.
good morning once more again, and thank you for staying with us till this time. So in this second talk, I'm going to be talking about breast cancer in sub-Saharan Africa. This has been the subject of my PhD thesis for the last 3 years, and I'm going to present some of the key findings we have had. So why study breast cancer in Africa? As said earlier, breast cancer is the most common cancer in sub-Saharan Africa. And in 2018, there were an estimated 170,000 new cases of breast cancer diagnosed in Africa. It is the second highest cause of cancer deaths after cervical cancer in Africa, with approximately 70,000 deaths in 2018, according to GlobalCan. We have high mortality to incidence ratios in sub-Saharan Africa compared to developed countries. What does this mean, this high mortality to incidence ratios? The graphic on the right is taken from the Cancer Atlas, and what we have in pink are the incidence rates from breast cancer. And what we have in gray, this tells us the mortality from cervical cancer. I want us to focus, for example, in Western Africa. So what is in gray is the mortality rate, which is quite similar or slightly higher than what you have in Western Europe, although the incidence is much smaller. So although we have relatively fewer cases, our mortality rates are very high, which implies that the survival from breast cancer in sub-Saharan Africa is relatively poor. Furthermore, we have limited availability of data at the population level to understand the actual breast cancer burden. So when we talk about population level data, this is important because it tells us about the general population, not only those who can make it to a particular health facility. So what have we learned from the work of the African Cancer Registry Network? The first question we've been able to answer is how are breast cancer incidence rates changing across Africa? In order to do this, we included data from 12 population-based cancer registries with at least 10 years of continuous data. And what have we been able to find out? So this graphic shows 3 time periods from 2000 to 2004, 2005 to 2009, and the last period is in blue, 2010 to 2014. And this tells us the cumulative risk or the risk of getting breast cancer before age 75. So what we observe first is that we have differences in magnitude, meaning that in some parts of Africa, we have higher cumulative risk, like higher chance of getting breast cancer before age 75 than in other parts. We observe relatively highest rates in some of the island nations of Mauritius and Seychelles, but we equally see high rates in the urban centers of Kampala and Harare. And we observe that these rates are increasing over time. And I would show these are urban centers like Kampala, Harare, Brazzaville, and this is in contrast to like this is the Eastern Cape Cancer Registry, which is like the only rural registry which is included. And this is important because it shows that although the rates in this rural area are lower than the rates in urban areas, but we are still seeing an increase in incidence rates even in the rural parts of Africa. Another thing to note is that the breast cancer incidence rates in women 50 plus, which is showed in pink, are higher than for younger women. And this was important to show because a lot of the clinical series always report the high proportion of women with breast cancer under the age of 50. This is high because the population pyramid of Africa is younger. So the majority of our population is young or under the age of 50. So if we look at a cross-section of the population, there will generally be a higher proportion of women presenting at the hospitals. But if we look at the incidence rates, which is the number of new cases divided by the population at risk, we see that the rates in women greater than 50 are rising faster and are generally higher than the rates for women under 50 in almost all the registries we studied. The next point or the next series of questions we're trying to answer are what are the survival rates for women with breast cancer in sub-Saharan Africa? Prior to this work this collaborative work from the African Cancer Registry Network, data from only 7 sub-Saharan African countries had been published on population-level breast cancer survival. And there was great variability across the continent from these rates which had been published. Sankarayanan had rates of about 12.5% in the Gambia, and with rates about 42% in some registries in Africa, like Kampala and Harare. So we noticed this huge variability, but with using more recent data sets, we were able to see what were the survival rates for women in sub-Saharan Africa. So how did we do this? We included data from 14 of our population-based cancer registries. We included approximately 2,500 women diagnosed in the period 2008-2014. The mean age at diagnosis was 51 years with a median of 50 years. It's important to note that 65% of our patients were diagnosed at stages 3 and 4. This is similar to some of the work done by Dr. Elima, who is present here, and collaborators, in which we found that approximately 70% of women in sub-Saharan Africa are diagnosed at advanced stages. This was mostly from hospital series, but even from a population-based registry report, we are seeing that approximately 7 out of 10 women will present at stages 3 and 4. Furthermore, 1 in 5 women in sub-Saharan Africa will present with metastatic disease. Another important characteristic of our cohort was that we had a relatively high proportion of loss to follow-up in the first year after diagnosis, with 14% of women lost to follow-up. The results we present here are very different from what we have in Western countries, because as a result of screening, the majority of patients are picked up at early stages, stage 1 and 2. But in sub-Saharan Africa, we see the countries in which approximately 7 in 10 women will be diagnosed at advanced stages. So the importance of downstaging breast cancer in sub-Saharan Africa. When we look at the survival results, we see once more this great variability in survival from breast cancer in sub-Saharan Africa. 1 year after a breast cancer diagnosis, when we compared registries from Namibia to Bulawayo, we see rates which go from approximately 80% at 1 year to about 60%. But when we look at 5 years after diagnosis, once more, we see this very low rates of less than 20% in some parts of Africa. And in richer and more wealthy African countries, we have survival rates which are higher. So when we try to fit these results in a model, like just trying to see like if we adjust for the age and the country human development index, what we notice that the countries who are richer, that's from a medium or high human development index, patients will generally do better. Or else, in this case, the hazard ratios of women who reside in countries with low or medium HDI is generally higher, meaning that more of them will die from breast cancer. And when we looked at stage, as expected, women diagnosed with late stages or women for whom we did not have the stage at diagnosis recorded had poor survival outcomes compared to women who were diagnosed at early stages. Hence the importance of downstaging breast cancer in Africa. Next, the question we ask next is that what is actually driving these differences in survival, which we observe in our registries? In order to do this, we did a more in-depth study in collaboration with Dr. Eva Kantelhart and the University of Halle, and we did like an in-depth look into the registry records of 800 patients from 11 population-based cancer registries. And what were the key characteristics of this cohort is that for 1 in 5 patients, we had recorded information on the stage at diagnosis and the hormone receptor status. It's important to have stage and hormone receptor status known because this is important to follow treatment guidelines. For a majority of women in our cohort, the hormone receptor status was not known. This tells us if the tumor is either hormone receptor positive or negative, and this influences treatment and survival. For 55% of women with curable breast cancer, meaning that with breast cancer diagnosis stages 1 to 3, they received either inadequate or they had no cancer-directed therapy. And there were differences in access to therapy by registry area. So when we look at these differences in access to care, if we still remember the previous slides, we saw that patients in Namibia had very good survival comparatively to some patients in Kampala. And now when we dive deeper, what we have in green are patients who initiated adequate therapy. And what we classified as adequate therapy are patients who had surgery and some kind of systemic therapy. Systemic therapy means either chemotherapy or endocrine therapy. So for patients, so what you have in green are parts of Africa where this subset of women with breast cancer received adequate therapy. And we see this variability in our different registry areas. So some of the differences in survival which we observed, which were reflected in the differences by Human Development Index, is actually differences in access to care by women with breast cancer in this registry.
2 minutes.
Furthermore, we equally have differences in stage of diagnosis. What you have in green are like women diagnosed at stages 1 and 2. And when you have colors changing to amber and red, these are women diagnosed late. So when it comes to stages at stage of diagnosis, for some parts of Africa, like Namibia, we have more women who were diagnosed at earlier stages compared to other parts of Africa in which we had more women diagnosed at late stages. So we are seeing two things which are in play here, both the stage of diagnosis and access to quality care. So when we looked at like putting all the variables together, we see what was important is what made women have like poorer survival is being diagnosed at late stages, not having access to adequate adequate surgery, receiving not inadequate chemotherapy, and not receiving endocrine therapy. But I would say this is just an observational study, and meaning that there are equally other things which we may not have adjusted for, but this just gives us an idea of some of what may be driving the differences in breast cancer survival observed in sub-Saharan Africa. So in summary, I would say breast cancer incidents are rising in many parts of Africa, and this may be related to our changing lifestyles. We have higher incidence rates observed among postmenopausal women. Survival differences are observed across Africa, and these are driven by differences in stage of diagnosis and access to quality care. We are grateful for the work of the registry, which made this kind of data from population level data in Africa accessible. So we're really grateful for the work of the African Cancer Registry, but it's important to continuously improve the availability and the quality of data from the African continent. Thank you very much for listening.
Thank you. Yes, it's important to look at the researches on the population-based level. Our next speaker is Dr. Elima Jodi Abba. She's a senior research scientist based in the International Research Council of Excellencies in Nigeria. And she will be presenting cervical cancer incidents in the continent. The stage is yours.
Okay, thank you, Bing. Okay, so good morning, everyone. I'll be talking to you today about trends in cervical cancer incidence in sub-Saharan Africa. And this work was done during my time on an AFOX fellowship at the University of Oxford, working with the African Cancer Registry Network. So it's a collaborative study. We worked with about 10 cancer registries across 8 sub-Saharan African countries. And the list of the collaborators is here. So on this slide, so this work is a collaborative effort of all the people listed here. So just as some background, cervical cancer is the most common cancer in about half of all the countries in sub-Saharan Africa. And the other half, we have more of breast cancer. And Southern Africa reports the highest incidence rates of cervical cancer worldwide. Also, about a quarter of all cervical cancer cases die from the disease. So survival in the region is quite poor. And looking at the incidence, we can see that sub-Saharan Africa is disproportionately affected by cervical cancer compared to other regions of the world. And this is the same for mortality, which is different from the picture we see for breast cancer, where we see more incidence in the Western countries, and then we have higher mortality in the poorer countries. But for cervical cancer, we can see that for both incidence and mortality, sub-Saharan Africa is much more affected than any other region. So in 2018, according to Globocan, about a quarter of all cancer deaths in sub-Saharan African women were attributed to cervical cancer. And data on cervical cancer trends from many sub-Saharan African countries is scarce, at least published data that is of good quality. And so there have been a few studies from individual countries in Uganda, South Africa, and Zimbabwe. But this is the first study that put together data from multiple countries together. So here we investigated trends of cervical cancer incidence in registries that are part of the African Cancer Registry Network and had data for periods spanning 10 to 25 years. So what were our study aims? One, we wanted to determine what the incidence of cervical cancer was in sub-Saharan Africa. The second was to monitor the trends over time. And lastly, we wanted to investigate the interplay of cohort and period effects on cervical cancer incidence. Our data sources were 10 population-based cancer registries across 8 countries in the region. And we looked for data of consistently good quality for a period of 10 years and more. That's a list of the registries that are included across Western, Eastern, and Southern Africa. And then we abstracted cases of cervical cancer and uterus from the registry, excuse me. And population data, excuse me, from census estimates. I'll just take a break, please.
Yeah, I hope you're feeling better soon.
Okay, I'm back now. Yes, thank you. Oops. Of 52 to 98%. 3 of the 10 registries had national coverage, and cervical cancer incidence rates are increasing in 9 of 10 countries. Sorry.
If you need a few minutes, I could play the.
Yeah, I'm having trouble.
That's fine. I will bring up the next talk. So let me bring up the next talk.
Let me share again.
Oh, okay.
Okay, so my slides seem to be stuck. Oh, it's not moving. Okay, hello, Bing.
You are loud and clear.
Okay, great. So sorry about that. In terms of the results, we had 21,990 cases of cervical cancer. And for morphological verification, it ranged from 52% to 98%, with more than 70% morphological verification across the registries. 3 of the 10 registries had national coverage, while the other 7 just covered some portion of the population. And we found that cervical cancer incidence was increasing in 9 of the 10 sub-Saharan African countries studied. So for 2 of these countries where we didn't have enough cases per year, there were very few annual cases, we looked at the trends in incidence by period of diagnosis in Seychelles and Bulawayo. And we can see that in Seychelles, from 2004 to 2009, compared to the later period 2010 to 2015, there was an increase in incidence of cervical cancer across the 2 time periods. The same for Bulawayo, from 1963 to 1972, compared to 2012 to 2015, which was the more recent time period, there was also an increase in incidence. And then also looking at the incidence trends annually in the Blantyre registry, we can see that there was an increase over time in incidence of cervical cancer. The same in Harare, where you can see there's a discontinuation there of the line, represents about 3 years where there were some issues with cancer registration in the registry. They had some challenges and registration wasn't so good at that time. So that's why there was some disruption there. And in Eastern Cape as well, we've also seen, this is more of a rural registry like the previous speaker talked about. So we can see here that the incidence is increasing across all these registries. So the only country where we found a declining incidence was in Mauritius. And here we found a significant decline in incidence over time. In terms of looking at the cervical cancer incidence by period of diagnosis and by birth cohort, we're able to look at this in 2 registries, in Harare, Zimbabwe, and in Kampala, Uganda, because these 2 registries had data for a period spanning 25 years. So what we saw was that increase in incidence over time involved all age groups and across all time periods. And when we looked at this by birth cohort, we saw that there was an increase in the middle age range between successive birth cohorts. So for more details on this study, our work has been published in the British Journal of Cancer earlier on this year. So you can read our paper on that. So just to summarize what I have said, the highest age standardized incidence rates of cervical cancer were reported in Eastern Africa, Harare, Bulawayo, and Malawi, and in Uganda. The lowest age standardized incidence rates in our study were in Mauritius and in Seychelles. And of course, this may be as a result of the fact that these countries are more middle-income countries now, and there's also a very large cervical cancer screening program at the Victoria Hospital in Mauritius. And this is in contrast to what we saw for breast cancer, where we had higher rates, incidence rates of breast cancer in Mauritius and in Seychelles. So incidence rates, they are rising in all registries for some time periods, except for Mauritius, where we noted a decline. And also to extend this work, we have put in a grant application to the Medical Research Council. This is in collaboration with AFCRN and University of Leicester, where we plan to look at population level stage at diagnosis and cancer survival across 4 registries in Nigeria. So we hope to hear back on that application by December this year. So to conclude, just a thought about why incidence rates are rising in most sub-Saharan African countries. I think one of the key things is chronic HPV infection in the region. And of course, this is a necessary cause of cervical cancer. The second is the high prevalence of HIV. So we can see from the map there that the areas where we have high prevalence of HIV, also have high incidence of cervical cancer. Also, there's a lack of population-wide cervical cancer screening programs across the region. And again, there are also changes in reproductive factors, including the early age at, for example, early age at sexual debut. So a lot of these changes are contributing to the rising incidence rates that we are finding in many of these countries. So in terms of challenges to cervical cancer control in Africa, one is there is inadequate support for sustaining cancer registries in Africa. So we find that, sometimes the registry starts, but then the thing is the sustainability. So there is a lack of funding to sustain the activities of the cancer registries. Also, low socioeconomic status is also an issue in the region, and we know that this is one of the risk factors for cervical cancer. And then there are also weak or underdeveloped health systems. So the health systems are already combating epidemics of infectious diseases, and most times are not able to adequately cope with an added strain of NCDs and cancers. And lastly, the COVID-19 pandemic is affecting the willingness of women to even access cancer screening and care. So in terms of the opportunities for cervical cancer control in the region, we've noted from this work that there is rising incidence in sub-Saharan Africa, and this is across all the regions in sub-Saharan Africa. So this really is of concern. One of the first things we need to do is prioritize cancer registration to fully characterize the burden, to monitor the trends and the effectiveness of cancer control strategies. The second is to introduce and scale up HPV vaccination. And one thing to note is that all these things can't be done in isolation or in silos. They have to be done together. Because, for example, even if we introduce HPV vaccination now, we won't know the gains of this until the people who are vaccinated get to the age where they are at maximum risk of developing cervical cancer. So essentially, we still have to introduce and expand our coverage of screening and the treatment of precancerous lesions in the region. There also needs to be prompt management, diagnosis, and treatment for invasive cancers, and also access to palliative care for cancers that are late stage. So I'd like to acknowledge a lot of contributors to this work. One is Max Parkin, Being of AFCRN, Yvonne, and all the cancer registry staff of the participating registries who contributed data to this. Thank you very much.
Thank you, Elena. Thank you for this piece of very important and interesting studies. And it's very interesting to see that the trends of cervical cancers is rising in the continent. So all the interventions you just mentioned are needed urgently. And we hope to see the actions being translated into material soon too. Our next speaker will be Dr. Tobias Serafin from Germany. When he was doing this study, he was a medical student at the Martin Luther University, Halle-Wittenberg in Germany. And now he's already a busy clinician based in the Heinrich-Heine University, Düsseldorf. Because of his time schedules, he has recorded his talk in a video. I would like to try whether it works. Can everyone hear his voice? Hello?
No, you can't hear.
We can't hear.
Hi, Being, we still can't hear.
Oh, let me see what other setting. I'm so sorry. I thought you said you could hear. Share computer sound. Let's try again. Can you hear?
We can hear you, but not Tobias.
Oh. It says share computer sound. Optimal screen for sharing video clips. No, as I play, still no sound.
I think we hear you, but not Tobias.
Okay, let me do some tricks.
MD at China University in Düsseldorf, Germany. I did my research on prostate cancer in sub-Saharan Africa at the Martin Luther University in Halle-Wittenberg.
How is it?
We can hear now.
Working together with the AFCRM during the last years. So now I want to present you the 3 studies we did on this global can map. Hello everyone, my name is Tobias Paul Berafin and I'm an MD at China University in Düsseldorf, Germany. I did my research on prostate cancer in sub-Saharan Africa at the Martin Luther University in Halle-Wittenberg and was working together with the AFCRM during the last years. So now I want to present you the 3 studies we did on this global can map. You see the top cancer country by the estimated age standardized incidence rate in male in the year 2018. And as you can see, prostate cancer is the top cancer in 118 countries. And this is also reflected in Southern Africa, where nearly all of the countries are green. And even though this is the case, during some literature research, we found a big evidence gap. population-based evidence. So we don't know about incidence trends. We don't know about changes in the incidence. We don't know about the diagnostic workup or the distribution of stages on a population-based level. And we don't know which treatment is the average prostate cancer patient receiving in Sub-Saharan Africa, and what is the survival of those patients. In our first study, we analyzed the time trend in prostate cancer incidence. We took data from both AFCN registries and included all patients registered in a certain time period. And here you see the chart of this publication. And on the left-hand side, you see the age standardized incidence rate per 100,000 on a log scale. And the x-axis shows the years of diagnosis. So, for example, in Mauritius, on the bottom left, you see the black dots reflecting our yearly estimates, and the black line showing the 3-year moving average. And you already see a slow increase of these dots and pulling the line. And we put a regression into that and estimate the annual percentage change, which showed that there was a 2% increase annually in Mauritius. And this is a trend we could see in nearly all of the Sub-Saharan African countries or registries we looked at. And we found the highest rates, for example, in the Seychelles, we found a 10% annual increase in the incidence rate. On this chart, you see GlobalCan estimates for the number of patients in 2014. So they estimated that despite demographic changes, the number of prostate cancer patients in Africa will double until 2040. But if you take a risk change of 2% annual increase, like the lowest annual increase we've seen in our study, the number of patients will quadruple until 2040. And this is just to emphasize that prostate cancer will become even a bigger problem in the future. So the second study we did, we took a random sample of around 700 patients from 11 AFCN registries, and we tried to trace them back into the hospital and try to find their medical records and see the diagnostic workup that has been done for their cancer. So you see E-stage, PSA level, and treatment score here. And the biggest bar on the right-hand side with 328 patients, it shows that when no medical records were found. So we have a lack of medical record keeping, which is a big problem when doing research, retrospective research, that's the case. And then we also had a big problem that of those medical records found, the majority of records didn't include any information on E-stage or PSA or Gleason score, and these three factors are the main risk factors to predict the progression of the disease and accordingly, the allocation of treatment.
So here you see that the majority of patients didn't receive any diagnostic workup, or maybe they received it, but it hasn't been documented, so we couldn't find it. So we have a lack of diagnostic workup. And then when you look at the information we found, we have late stage presentation, and this is shown in E stage, where nearly the half G3 to G4, and PSA level we have 85% above 20 nanograms per milliliters, and also 40% have a Gleason score above or equal to 8. This is in line with another finding on M stage. So 1/3 of all prostate cancer patients we had in our sample and found information for M stage were metastatic. If you compare that to the US, you see that in the US there is no such late stage presentation, since only 6% of cases are in metastatic stage. The study also included an analysis of the treatment approaches being used. And here you see in this chart the non-metastatic patients as orange columns and the metastatic patients as red columns. And you can see that just a small percentage, and being precisely, it's 17 to 18% of non-metastatic patients received curative treatment approach, meaning radical prostatectomy or external beam radiation therapy. And also looking at all the patients, we found that a rough quarter didn't receive any cancer-directed approach, so no hormonal therapy, no surgery, no radiation therapy. So this reflects that many prostate cancer patients are not treated. Now, in a study from Ghana, they found 56% with curative intent therapy. And this is just to show you that there are centers in sub-Saharan Africa where the treatment for the majority of patients is quite good. And they also have good survival, which you can see in this study if you look at it. But this is not the population-based picture. So this is just a hospital-based study and just refers to the patients being referred to this place. This is just to emphasize the need for population-based data to get the real picture of the situation on the ground. In our third study, we took a random sample of around 1,700 patients from 12 AFCN registries, and we wanted to know what is the age-standardized relative survival of those patients. And here you see a chart of the age-standardized relative survival by registry.
Good afternoon, everyone. My name
Hello, everyone. My name is Paul Dervin, and I'm an MD at China University in Dortmund, Germany. I did my research on prostate cancer.
To know what is a registry, and the pooled cohort had a relative survival of 60% after 5 years, but the rates varied substantially. So we have Eastern Cape here with a very poor survival, and Nairobi with quite a good survival, and also in between the registry lineup. But if you compare this to the US, where 98% of prostate cancer patients survive 5 years, you see that there's still a big gap in between. And also in the UK, 87% of prostate cancer patients survive 5 years. In conclusion, we saw in our studies that prostate cancer is now already a major problem for sub-Saharan African health system, but it will also be even a bigger problem in the future since the rates are rising. And even now, we need to improve the diagnostic workup, and we need to raise awareness in the population for this disease so that people present earlier. And we need to invest into the health facilities, like the surgeons, urology departments, and radiotherapy units to lower the rate of patients not receiving any cancer-directed treatment, and also maybe improve the general survival of prostate cancer patients. So I want to thank you very much for your attention, and I want to thank all the registry directors and staff from the AFCRN for their great work and all the contribution to our research. So keep up the spirit. Thank you very much.
Oh, my apologies for the few technical challenges. Our next speaker will be Natasha Abraham from the South African National Cancer Registry. So also due to a clash of schedules, she has recorded her presentation as a video. Come on.
Good afternoon, everyone. My name is Natasha Abraham, and I'll be talking about the childhood cancer surveillance in Southern Africa. Childhood cancers are cancers diagnosed in children aged 0 to 14 years old. Currently, there is limited data available on childhood cancers in Africa. As you can imagine, this poses a problem as we need reliable numbers for the planning and evaluation of services for cancer prevention, early detection, and treatment. Without the information on the size and the nature of the cancer problem at the population level, it becomes very difficult for the governments to plan accordingly. The African Cancer Registry Network has successfully established national registration of childhood cancers within population-based cancer registries in 3 countries as shown here in the different shades of red: Burkina Faso, Côte d'Ivoire, and Republic of Congo. What we aim to establish with this project is to successfully replicate what was done in these 3 countries in 5 additional countries in Southern Africa, so that the pediatric cancer surveillance for the region can be strengthened. The 5 additional countries are shown on the map in the different shades of green: South Africa, Eswatini, Botswana, Zimbabwe, and Zambia. Our work is going to be funded by the African Oxford Research Development Award. The principal investigators for the study are Dr. Mzvita Machingeti at the National Cancer Registry of South Africa and Dr. Max Parkin at the University of Oxford. I will be acting as the project manager for the study. The grant was awarded to the National Cancer Registry of South Africa, and the funds will be managed by AFCRN. Our study period is for 11 months ending in July 2021. The objectives of our project is to ensure that there is dedicated staff trained for childhood cancer registration within each of the registries, to ensure that we collect accurate data on cancer incidence and cancer stage or diagnosis in children by type, age, sex, and ethnicity for the national populations. We want to make sure that we record data on stage in at least 80% of the registered cases. We will also do survival analysis for the major cancers of childhood by stage, stratified by sex and age. The main activities of our project will involve identifying different sources of data and collecting the incidence data on childhood cancers, using the Toronto staging guidelines as prescribed in the book shown over here. In Africa, we'll mostly be focusing on Tier 1 of the Toronto staging guidelines. We will also be following up on the outcome of the patients. The training was meant to be an in-person training in Johannesburg, South Africa, but unfortunately due to the COVID-19 pandemic, we will now be doing the training in an online format. Videos have been created and shared already on the African Cancer Registry Network website. The training content covers introduction to childhood cancers, coding, and the Toronto staging. This will be followed by a post-training questionnaire to ensure that there has been successful transfer of knowledge. We are planning on site visits in 2021. Although our study period is relatively short, we hope for many long-term outcomes from this project. starting with producing an annual report on childhood cancers and incidences in stage in Southern Africa for the years 2018 and 2019, with the incidence rates having 90% accuracy in terms of completeness and validity. The annual reports, in turn, will allow for childhood cancers to be integrated into national cancer control plans based on the data collected from the registries. This data can inform strategies for screening, diagnosis, treatment, palliative care, and so forth for each of the individual countries. The annual reports will also present leverage to lobby for legislation to make reporting of childhood cancers mandatory. Currently, only one country of the 5 where the project includes has cancer as a notifiable medical condition. And ultimately, we hope that this in turn will strengthen the long-term standing of the cancer registries within their respective Ministry of Health to ensure that there is sustainable surveillance activities going forward. I would like to thank the following institutions and individuals for their contribution towards this project. Thank you.
Okay. Thank you all. We are a few minutes over, but I'm sure our next speakers, Mirato, will be able to keep our timeline. Mirato? So Lerato is the manager of the Economy Cancer Registry in South Africa, and she will be giving a presentation on how COVID-19 has affected her work lives and as well as work among the surveillance workers in South Africa. Cool. Good. Whenever you're ready.
Sorry, I forgot to. Let me just load my screen again. Sorry, Being.
Mm-hmm. Yep.
Are you able to share the screen that I've sent you?
Right. Okay.
Okay. In the presenter mode, because now I have a problem.
That is fine. Share your screen.
You can do a presenter mode, yes.
Just let me know when you want me to click.
Just a minute, I think I can get this fine. Sorry, I had my screen ready and then something happened. Okay, can you, can I just do my screen again?
Yeah, you can try.
Yeah. Can you see my screen?
Not yet.
I'm not showing my screen.
No, not yet.
All right. I thought I'm doing it. So maybe you can just share my screen again, because I'm failing again the side. I don't know what's happening.
That's all right. We all experience that.
So that's fine. So you can just press that, the next slide. As we all know that I'm from South Africa, which has a population of about 9 million people, 60 million people, in 9 provinces. And Gauteng is one of our main provinces. Can you just click for me there? Gauteng is one of the most populated province, and that is where our National Cancer Registry is at. We're mainly a youth. Our age distribution is mainly youth and majority Black. We do have minority races such as Caucasians, mixed race, and Indians. We can go to the next slide. The National Cancer Registry has been running the pathology-based registry since 1986. And since 2011, we had regulations that said to everyone that they should actually report cancers to the National Cancer Registry. Next slide. Because of that regulation, there was a huge increase in our pathology-based cancer registry, because all laboratories now, even the private ones, started to report to the cancer registry. But also the regulation mandated the NCR to start population-based sentinels in South Africa. You can just press the whole slide for me, perhaps. And that brought us to the inception of the Ekurhuleni-based population registry. So if you could look on our map there, that's where our Gauteng is, where I've pointed in blue. And then our Ekurhuleni is just by the eastern borders of Gauteng there. And that is our first urban population-based registry in South Africa. Maybe just press the whole slide. So for all this, the Ekurhuleni population-based registry, what we did was to do passive and active surveillance in all hospitals or facilities in and around Ekurhuleni. If you can see one of the pictures there, we see that there's our public hospitals are generally very overcrowded. And then for data abstraction, we have surveillance officers who would normally have access to all the healthcare, all areas in the healthcare facilities that they're at. The last picture there, you can see one of our surveillance officers being at doing data abstraction at the our patients filing system. We could go to the next slide. Then we had COVID-19 pandemic, which then the government enforced lockdown, which lasted for about 6 weeks, and there was no cancer surveillance, and our streets were actually we had soldiers all around to make sure that nobody's walking around. Next slide. So to prepare for the COVID-19 regulations, there was a lot of changes that had to happen in healthcare facilities, prioritizing COVID-19 related activities and patients who had COVID-19. One of the things that happened is that the lockdown started to relax, and as it was relaxing, then we started having being able to go back and do cancer surveillance. However, there was a lot of changes, and that was the time when COVID-19 cases started to go up in South Africa. Firstly, there was a lot of facilities had very limited access. We had to have COVID-19 testing, which was facilitated by hospitals. And then most of the facilities, what they did was to sort patients according to their COVID status. So as you can see in that picture, we can see that there's surgical, that's the surgical ward, but it's mainly for COVID positive patients. Now, that actually arrangement was not working so well, because you would see that most of the patients would get into the healthcare facilities and they wouldn't have their pathology results of COVID-19, which means they could not be sorted according to whether they are COVID positive or negative. And they would have to be in a mixed area where they would have be treated, but waiting for their COVID-19 results until they can get sorted around. Now, those areas became one of our epicenters for COVID-19, because a lot of people would get in there. A patient would get in to get a baby and come out with a baby and with COVID infection. We can have the next slide. Yeah, we can. I think all the slides, we can just do everything for the slides. Yeah. So as we know that South Africa, we ranked top 5 in the world. There was a really bad surge of COVID-19 around South Africa, especially between June to August 2020. There was a time that we were actually recording about 500 cases of new COVID per hour in South Africa, and that was a really bad time. If you can look at our that map at the top, where it shows the COVID numbers distribution, you would see that the Gauteng, again once more, was also where the Ekurhuleni population-based registry was also one of the epicenters. And then we had a problem that most of the facilities or the hospitals or whatever you can call them, they would get periodically closed because the staff members used to get very sick. Our recovery rate in South Africa was very good. We had about 90% nationally for just the general population. However, for the healthcare workers, there was a recovery rate that was very low at about 58%. And hospitals became a huge epicenter for COVID-19. Next page. So our surveillance officers had to face a fact that they had all access to all areas in their facilities, to very, very limited access to the facilities. And frequently they would go into a certain facility or a clinic, and only to find that there were a lot of healthcare workers that were sick, and now the facility had to close because they had to disinfect for COVID-19. And if you can look at that that top picture, you would see patients going into the hospitals after traveling for a long time, only to find that they're looking at locked gates. Most of the time, our cancer surveillance people had to forage for cancer cases not working systematically anymore because they didn't know what was, they were barred in so many areas and they had to see which area they can work per day instead of working systematically as usual. Our surveillance officers got very emotionally affected because most of them were scared of getting COVID-19 infections. Also, they were just surrounded by death around their facilities of patients and especially of co-workers who they felt that it was like part of their colleagues because they are mainly at those facilities. Next page, please. So our healthcare system went to overpopulated because of COVID-19 to very deserted places. Next. We obviously have a decrease in healthcare seeking behavior in our population-based, our population, or perhaps even globally. People don't want to go to healthcare facilities because they'd rather stay with their cancer or with their lump in their cancer than go into healthcare facilities to go and get COVID-19. Now, this decrease in healthcare seeking behavior is going to have a rippling effect, especially in our numbers of the incidence cases that we'd be reporting in all the registries, whether it's hospital-based, pathology-based, or population-based, because people are not coming to seek healthcare. One of the possible solutions that we can do is to just increase healthcare awareness campaigns, whether through media or all other things. I remember when we were small, we were bombarded by cancer can be beaten as long as it's found early. So those are the, campaigns have to just go up so that people can go back and not be scared to go to healthcare facilities, because COVID, we haven't got a cure right now, and it looks like it will be there for some time. We also need to have a constant emotional support to our surveillance officers, as they are like frontline workers, as they see a lot of all this in the healthcare facilities that they're having. Now, since we're going to be having all this, we know that there'll be a lot of decrease in cancer incidences in our. I'm asking that perhaps the cancer registry networks could give like a uniform guidance on how we can actually deal with these decreased incidence rates that we are going to be seeing because of this pandemic. And thank you very much. I think that's my last slide. I would like to thank all the people, the National Cancer Registry, and everyone. Thank you.
Oh, thank you very much for the very touching presentation. I'm quite sorry to hear that only half of the medical staff managed to recover from COVID. Well, I do hope this situation is better than in other countries, but this COVID has certainly affected us all, physically and psychologically.
Yes.
Yes.
We were very fortunate at the National Cancer Registry. We had about 3 cases, and all of us actually recovered well.
Yes, I am aware some of our colleagues on this call have had COVID themselves. Your last questions posed to give uniform guidance on decreased incidence rate across the registries. I guess that's a question to both Dr. Parkin and Dr. Bray. Would any of you like to take on this question or comment?
Yes, well, very quickly, we don't have much time for discussion, but yes, it is going to be a problem for all of us, isn't it? And I suspect in the end, we're going to have to adopt a solution like the one that I think it was Elima showed for Harare, that when there's a crisis that affects the healthcare in a country, that the registrations are going to be out of line with what they should be, and we just have to ignore those years. some of you might remember seeing that graph for Zimbabwe, which was reflecting a crisis in economics and healthcare at the time. So we just dropped those years from consideration. I strongly suspect we'll have to do the same with our data from 2021 in Africa.
We have 2 minutes left. Any burning questions? Dr. Bray, are you still around? Would you like to say a few words to the team?
I think he had to leave to the IACR meeting. Do you remember?
Right, okay.
Presentation, so I think he's been called to that.
Okay, all right. So if no other questions, I would like to thank all the speakers and participants for their time and for showing interest in our work. It's clear that cancer registration needs a lot more attention and support than it is now. And the importances and the urgencies have been talked about over and over during the talks today. Yeah, thank you, everyone. Couldn't have this session without all of you. So thank you.
Thank you.
Thank you, Dee.
And
Thank
any
you.
questions, feel free to contact me.
Thank you. Bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye. Great work. Bye.
Bye. Bye.
Thank you.
Stay safe, everyone.
All right.
Thank you. Play safe too.